All right, everyone. So again, my name is Laura Pegram. Thanks so much for joining us today. I'm, as you all know, the manager of drug user health here at NASDAQ. And this is the first call of our quarterly drug user health calls. I'm joined here in the office by Alyssa Kitlis, who's our manager of hepatitis here at NASDAQ. And she is helping me graciously with all the technology, so I really appreciate that. So after receiving all the, a lot of feedback from different participants on the call and hearing about the different topics that you'd like to have covered, which I really appreciate, we decided to go ahead and have this first topic be a pretty general one, but super important that I heard from a lot of folks to really start addressing stigma surrounding drug use and drug user health efforts within communities. And specifically, we wanted to hear from a couple different programs and people who represent those programs who created and work on anti-stigma efforts surrounding people who use drugs. And they have graciously offered to share their information today. So our hope is to have 3 distinct presentations and then have questions at the end. So just a little housekeeping. Like I mentioned in the email, but due to the number of attendees as being pretty high, we had to switch to kind of a webinar format. And so unfortunately, folks won't be able to ask questions by using their voice. They will have to use the chat box, which we encourage everyone to do. And we will have a question time sort of at the end. Just for everyone's information, we're going to go ahead and record this call so that NASDAQ can catalog it and make sure that we have the content available to our members for in the future. And lastly, we've blocked out an hour and a half for this call. But since it's the first one, I don't know if we're going to need all that time. So I definitely want to be respectful of everyone's time and make sure that, if the call is done, we will finish the call. So I appreciate everyone being on. So just a little bit about our speakers today. I'm just going to run through all of the speakers present, and then we'll kind of jump into presentations. So first, we're going to have a presentation from New Mexico. We're going to have Bernie Liebing and Dominic Zerlo. Dominic is the Hepatitis and Harm Reduction Program Manager from the New Mexico Department of Health. And Bernie is the Overdose Prevention Coordinator at the Santa Fe Prevention Alliance. And then he also works at the Department of Health and Human Services at the Office of Substance Abuse Prevention. So in each of their roles, they have been working on different stigma reduction campaigns and materials for both community and service providers. So that'll be exciting. And then after that, we're going to hear from Colleen Flanagan, who's the director of the Bureau of Hepatitis Healthcare from the AIDS Institute at the New York State Department of Health. And she's been working on an anti-stigma project that focuses on addressing stigma for people who use drugs in healthcare and community settings. And then lastly, we're going to hear from Lisa Rayville and Matt Slavey from the Harm Reduction Action Center in Denver. So Lisa is the executive director, and Matt is a visual artist and board member. At least he used to be a board member. And they're all going to tell us a bit about how they've been working to address stigma for people who use drugs within their community. So Dominic or Bertie, would you guys like to lead off?
Sure, this is Bernie. I think Dominic wanted me to start off today.
Cool.
Go right on ahead, Bernie.
Cool, thanks. I think it's important to talk about, and I don't have a formal presentation, but we started doing syringe exchange in New Mexico in 1998, and we started doing layperson access to naloxone in 2001. So we've been working in this arena and reducing stigma and discrimination for a long time in our work in New Mexico. And I think that once the federal government started paying attention to this issue nationally, and we had this influx of federal monies through the PEO and the FTR grants, we got lots of new players involved, and media folks and public relations folks that had not been involved in our work prior to that. And so we have created some formal campaigns around reducing stigma and discrimination associated with drug and alcohol use. And those formal processes are are very generalized and very focused on the public at large. What I think is really important to emphasize is that anti-stigma and anti-discrimination and solidarity work is really 24/7, and it is necessarily woven into every training, into every meeting, into every engagement that I have with the community, whether that's the community, whether our community professionals, whether that be healthcare and social service providers, whether that is people who are providing services to those experiencing homelessness, whether I'm talking to a group of people on probation or parole, whether I'm training law enforcement officers, anti-stigma, anti-discrimination, solidarity messaging is woven through all of that. And formally sort of codified, for lack of a better way of saying it, in our presentations. I mean, in the work that I do as a consultant and trainer for the Human Services Department, the Human Services Department leadership actually, requested that this kind of stuff, this kind of information be a part of our trainings across the board, no matter who my audience happens to be. I also think, and I know this isn't news to anyone, but it's really important to talk about intersectionality and how other oppressive statuses that they've been assigned play into exacerbating stigma and discrimination when you put drug and alcohol use on top of that, or specifically people who are injecting drugs. You can't separate these things, and so that needs to be a part of the conversation that we're having all the time as well. Even though we're almost 20 years into this in New Mexico, providing unused syringes and equipment to people and having access to naloxone and overdose prevention education for people with these drugs and their families and friends, it's still very common for me to be in a training and hear mumblings under people's breath about thinning of the gene pool, about just letting people die. So this is, although we have been very fortunate in New Mexico to have a history of providing services to people, because of the new federal focus and some of the new legislation that is passed in New Mexico, I'm engaging, mostly professional people who have never been exposed to this kind of stuff. So the pejorative language, the oppressive language, the sort of downright anti-human language about drugs and alcohol is still we're still fighting an uphill battle with that in far too many places. I think we have made some inroads with our big public campaign, A Dose of Reality. Fortunately, I have a small contract with the public relations firm that has been spearheading that, and I try to engage the project with information about the importance of the kind of language that we use, and that oppressive language informs oppressive practice, oppressive policy, and the importance of again understanding intersectionalities and the importance of us as professional people to be working in solidarity with the people that we're supposed to be serving and engaging to teach us how to do the work that we do better. So that's my nutshell spiel.
Thanks so much, Bernie. That's a great overview of bringing in the real human work that has to go into combating stigma, especially around people who use drugs. So thanks for that.
Sure. And I guess lastly, I think you have, the onus really is on us to speak out and speak up, and to ensure that we are as professionally appropriate, engaging people when they use pejorative language, when they dehumanize people, and really using opportunities as, again, in solidarity and as advocates to take educational opportunities, by the horns when we get them.
Yeah, I appreciate that. Really staying vigilant on language. That's great. Dominic, would you like to chime in?
Yeah, and thank you, Bernie. That really helped set the stage for what I was going to talk about. And Alyssa, can you actually show the program website first? So what I just wanted to do is just point out on our New Mexico Department of Health program website, we actually have a lot of materials for people to utilize, and they're available to anybody who wants them. And if you want to take them and even modify them, my email is on the website, so all you have to do is actually ask me for the original, the non-PDF versions, and I'm happy to share them. And it's actually been a lot of things over the years, because we have been doing this here in New Mexico for 20 years. As of February, we hit our 20-year for the first syringe service programs in the state. And so we have a lot of information that's been gathered up over the years, as you can see, as Alyssa's scrolling down through the website. And so we've got everything from the legal side with standing orders, protocols, administrative code, the actual statutes. We have, and actually if you can scroll up just a little bit to the educational materials, we have, and that's really perfect right there. You'll notice we also have things like pocket education cards, because, and what those are is they're business size cards. If you want to click on any one of them and open it up, that would be great. And anybody can print these on out, and we hand them out to our participants. So for example, this one is the Good Samaritan Law, which actually gives lots of kudos to Bernie, because he was actually in my position when this law got passed and really was instrumental in helping to get it passed. And we were the first state in the country to have a Good Samaritan 911 law with regard to people calling for opioid overdoses. And so what can happen is people can cut these different information cards out and actually laminate them or just hand them out to people on cardstock so that people have them around for them. And as we go through everything, we try to make sure that the language on them is everyday language that people can understand, so that it's easy to read regardless of education level of individuals. And most of them, and most of the items are also translatable into Spanish. And we have some of those on the website, and others we have that we've distributed out to our programs directly. So if we can go to the slides now. And so what I'm going to show you a little bit is the first part of our harm reduction and hepatitis specialist training that we do. Anybody in the state who is doing syringe services has to go through this training, and we require them to recertify every 2 years, because as anything, our program continues to evolve and change, and we get better at doing what we do. And you'll notice on this, just on this first slide, we have information that goes back for these presentations to 2002. And so we keep updating it and ensuring that people who contribute to this are included in that recognition, because one of the things that we also know is by providing some ownership in some of what we're doing, not just in the presentations, but also in the program itself, that we're able to help change the ideas surrounding stigma, because people start understanding more and more about what we're trying to do. And so we model what we do with our participants and what we do with the community by ensuring that people get credit for what they've done. So if we can go to the next slide. And so with that, one of the things that we do is we teamed up with AETC South Central, which is AIDS Education and Training Center. And so for this training, which is an 8-hour training, we're able to offer 6.5 hours of free CMEs or CEUs, depending on people's licensures. So of course we have to have the disclosure screen on here. And then we also talk with people about the fact that just discussing the issues about substance use, while it may be a trigger, and so we have that warning on here, we also really encourage people to stay to be able to push their boundaries a little bit on their own feelings that may be uncomfortable, especially with regard to stigma, because we may have people in the room who disagree. And we've had quite often in different areas of the state, especially some of the more rural or frontier areas, where people still, as Bernie mentioned, people still have that pushback on why do we even need syringe exchange? Why do we even bother with this? Those people don't care about it. So the first thing we do in the training, and if you'll go to the next slide, is we do a stigma exercise or an activity. And what this is, and we actually have a couple of them, this is just one of them. What we do is we give cards out to people with questions on them. And we usually do 3 to 4 questions. And then we give them a predetermined answer. So we ask them to step out of their shoes and put themselves in the person who is answering the question on the card. So sometimes it might be, for example, a farmer who, owns 500 head of cattle, lives, 40 miles away from any other town, but has found a ranch hand who has started using substances. Or it could be a housewife, or it could be a school teacher. And we use different scenarios for that. And the types of questions we will put on will be things to stimulate the discussion about stigma. And so it may be a question that even uses, either outdated language or language that itself is stigmatizing to help stimulate this discussion, like all drug users are lazy and homeless, or homeless people are just dirty and disease-ridden, or drug users or junkies don't care about their health or anyone else. And so then the different people are responding with either they agree or they disagree. And again, we ask them to put themselves in the position of the person on the card or the answers they have on the card and try to talk about what would it be like if they were that person and having to answer that way. So if, for example, the question was, if the question was, all junkies are, lazy and dirty, disease-ridden people. If they said that they agreed with that statement, then they would have to try to come up with what would somebody who really thought that people who use substances are just full of disease and really kind of talk about it. And then the people who said that were on the disagree side would actually be able to respond to it and be able to talk about, no, these people are human. They're just other people. They do care about their health. By just coming into exchange, they're making a step about their health. And so really engaging people with this. And so what this really helps, especially with providers, is to really get that thought process going about how are they examining things and their own thoughts within themselves, and to be a little introspective, but also for those who haven't experienced that pushback from other community members or other individuals, it helps to better prepare them if someone comes up to them when they're on an outreach and starts complaining, or lodges a complaint about, oh, we just found syringes in our front yard, and those sort of things. So really talking about what those kinds of issues are. Next slide, please. And by the way, we usually use about half an hour of time to really go into that exercise so that people really have a chance to explore the different ideas and thoughts that kind of come up. And we do it in a safe environment. When we first used to do that particular exercise, we would ask people to do it based on their own opinion, and we very quickly realized that was not a good way to do it, because what would happen is if someone had an opinion that didn't seem to mesh in with the idea of harm reduction, they would actually get ostracized for the rest of the class. And so in this way, what we do is we give them, this is what the opinion to express on it. And that way it takes it those decisions away from them, and so people aren't ostracized, even if it may be something that they are thinking themselves. But this way, you've been assigned a side to present on. So then after that, we spend about another half an hour really talking about the philosophy of harm reduction. And so this is just an example of some of the questions and statements that we have and that we use, such as asking people to think about why they're there. Why do they choose to work with people who use substances and the other communities we work with? Why is it important to understand about substance use? Talking about how is it complex? Why is learning how to talk about it something that's beneficial? So essentially what we're doing here in this presentation right now. And go ahead to the next slide. And again, here talking about non-judgmental attitudes and trying to ensure that we're non-coercive. Educating people. And we really see this as one of the primary goals and objectives of our training, so that we can ensure that the people who are delivering services actually understand what the goals and the motivation behind harm reduction really are. So, and one of the things in New Mexico, we do consider that syringe service programs are a part of the treatment continuum, and we really emphasize that syringe service is treatment. So go ahead to the next slide. And then this is, again, another slide we use for stimulating discussion. So we have all different kinds of terms up here, some of which would be considered terms that we would use on a regular daily basis, like harm reduction or overdose, works, cookers, and then others that are stigmatizing, such as junkie, addict, abuse, those people, and really talking about how in many different ways the language we use really affects and influences the people that we surround ourselves with, that we talk with, and the people that we're actually serving, and how we interact with them during exchanges. And so we really, again, on this slide, we spend a fair amount of time with this really just as the way to jumpstart the discussion about stigma language, and how we're not going to ask someone to stop calling themselves by a particular word or name that they identify with, but that we should be using positive terms in order to help influence and affect not only the way people think about themselves, but to really talk about self-esteem and feelings of self-worth, and really to be able to help raise people on up. And I know we're kind of getting a little bit more on time, so I'll go ahead and stop at this point. But I think this gives a pretty good idea of what we really try to do and how we try to suffuse everything in our training, in our community presentations. And part of what Bernie was talking about, just everything that we're doing, we're very cognizant about stigma and really making sure that people have thought about the language they use, have thought about how they're presenting towards other people, and really to try to engage people in a conversation in order to help them to better understand their own thoughts and processes. So thank you all, and I'm here for questions.
Dominic, thank you so much, and Bernie, thanks to you again. I really, just appreciate hearing so much about your work in New Mexico and how language and vigilance and respect for people who use drugs is really consistent and just a constant consideration in your work. So I just very much appreciate that, and I really appreciate hearing from both separate departments, divisions in New Mexico, because I think a lot of states are working hard to make those relationships kind of across department, and I think you all are a great resource for it. So again, thank you. Great. So Colleen, do you want to take us, to the Northeast?
Sure, absolutely. Hi, everybody. It's Colleen Flanagan. So Laura, am I going to advance my slides? I'm sorry. Or
you can just let us know when. We have it all in the slide deck here.
Okay. All right. Great. So good afternoon, everybody, and thanks to NASDAD for the opportunity to do a brief presentation today on a really exciting initiative that we are doing here at the New York State Department of Health AIDS Institute, called the Drug User Health Capacity Building Initiative. It's really building capacity to provide stigma-free care to people who use drugs. Next slide, please. So I don't think it's new to anyone on the call today that many people who inject drugs have experienced discrimination in healthcare settings. The work that I do is primarily focused on hepatitis C, and we know that the majority of folks who are infected with hepatitis C, especially the new cases of hep C, are as a result of injection drug use. And so we've heard from not only from patients, but also from providers who are champions within their healthcare organizations as they try to move forward and motivate their colleagues to do more hep C testing. They meet some resistance, and it's related to the fact that they do not want to provide services to people who inject drugs. And we hear the same from patients who do not want to go to the provider because they fear discrimination. And this is from the Australian Injecting and Illicit Drug Users League, where they did a survey back in 2012 and found that 80% of people who inject drugs have experienced discrimination in healthcare settings. Next slide. And so we know that stigma is pervasive, and so stigma impacts multiple areas of a person's life, and therefore represents the biggest barrier to care. And we all know that every individual, regardless of any type of risky behavior that they may engage in, they deserve access to quality health care. Next slide. And so the AIDS Institute, as you can see by this slide right here, we're not just all about HIV. Several years ago, we actually expanded the portfolio of services to include services around STD. It's been over 10 years since the Hep C program has been located in the AIDS Institute, and so viral hepatitis is under the umbrella of the AIDS Institute, as is LGBT health and drug user health. And so even though this initiative is focused on people who inject drugs, the AIDS Institute, in line with our Ending the Epidemic Blueprint, has been doing a lot of work around stigma associated with many other populations, including the transgender population, women, MSM, people of color, people living with mental health diagnosis. And so the work of the Drug User Health Capacity Building Initiative really complements all of the work being done by the AIDS Institute to really eliminate stigma and discrimination against all different types of individuals and populations. Next slide. And so now I'm going to talk a little bit about this Drug User Health Capacity Building Initiative, which I'm really, really excited about, and is really a collaborative effort across the AIDS Institute, and I'll talk a little bit more of that towards the end. So the initiative is a multi-session series to really help clinical sites, or what we call in New York State Article 28 healthcare facilities, build capacity to provide high-quality, stigma-free healthcare services to people who use drugs. It is a year-long learning collaborative. It was kicked off in October. As I said, targeting healthcare organizations. All of the organizations must apply to participate in this capacity building initiative. When they apply, they have to describe why they want to participate in the initiative, describe steps that the agency has taken to train or implement stigma-free care, and they also have to identify 2 leadership individuals to participate. So 2 staff people who are in leadership roles who can serve as champions and who can affect change within the organization. We couldn't do this work without our external advisory group, which provided input on the framework and all the various tools, which I will provide an overview of. The external advisory group included people who use drugs, harm reduction and social service providers, so individuals from syringe exchange programs, for example, clinicians, and our colleagues at the New York City Department of Health and Mental Hygiene. And so we have 11 organizations currently participating, and they range from hospital-based clinics, primary care sites, federally qualified community health centers. And so we're really excited to be able to offer this type of initiative to these organizations. Next slide. So these are the goals and the objectives of this initiative. I won't really go through each and every one of them for the sake of time. You can take a look at these, and I'll get more into the specifics on the next slide, please. So as I said, we have 11 organizations that are participating, and there are a set of expectations that they all must agree to. So they have to participate in 2 in-person trainings. So we had a kickoff meeting. As I said, in October, we brought them all together here in Albany. They have to agree to conduct a staff assessment. They have to complete an organizational assessment tool. They have to assess patient satisfaction. And then they have to participate in monthly coaching webinars. And I'll go into each of these in depth as I move forward. And there's evaluation. And so we really consider this. This is the first time we're doing this initiative. It's actually built off of an initiative that we have around trauma-informed care. So we don't know how this is going to work. We don't know if the tools that we're using and have developed are appropriate. We don't know what kind of impact this is going to have. And so we really see this as a pilot. And so all the organizations have to complete these various tools in the beginning, and then they will have to complete them 6 months after the initiative ends. So we're going to use that as a way to evaluate the impact of this initiative. And at the end of the day, we really want the individuals who are participating to be stigma-free champions within their organization. Next slide. So let's talk a little bit about the staff assessment tool. And I have to say, we combed the literature looking at various tools, various interventions that would be out there to help us with this particular initiative. And there was not a lot out there. Although we did find one validated tool called the Drug and Drug Problems Perceptions Questionnaire, or the DDPPQ, which is a validated tool developed by Dr. Hazel Watson in Scotland. And we made some modifications to that tool. So the tool includes basic demographics. It also includes 20 items around 5 principal concepts that construct staff attitudes: role adequacy, role legitimacy, role support, role-related self-esteem, and job satisfaction. And so we used those validated questions, and then we also added 9 additional items reflective of the staff's perceptions of the 7 organizational domains that you'll see when I go through the organizational assessment tool. All levels of staff that interact with clients are expected to complete this tool. So every touch point from the minute that the client walks into the healthcare setting, whether it be the receptionist, billing, someone in housekeeping, supportive services, the organizations had to gather staff assessment tools from each of those individual staff roles. Next slide, please. This is just a sample of some of the questions on the tool. I'm happy to share the tool with anyone on the call today. It is on a 7-point Likert scale, 1 being strongly agree, 7 being strongly disagree, agree. The lower the score is better on all domains. Higher scores indicate more need for improvement on all domains. Surveys could have been completed online or submitted hard copy to us here in the AIDS Institute for analysis. We performed analysis by organization and in aggregate. Each organization received their own data report, and aggregate data was shared via one of the monthly coaching webinars. Next slide, please. So the organizational assessment tool. So this tool is evaluating the policies and practices of the organization, not the individual staff performance. And so it's intended to help prepare the organization to provide stigma-free care to people who use drugs. It evaluates not only the policies, but also the practices of the organization. It's completed by a multidisciplinary team, including leadership. We ask that 1 assessment tool be submitted per agency. And so we've heard from the agencies that they completed it at multiple different staff meetings, or they had 1 long staff meeting where they completed the tool. And as I mentioned, the organizational assessment tool is comprised of 7 domains or areas of programming to be examined. So let's take a look at the next slide. Will show us what those 7 domains are. So the domains are access, assessment, treatment, and supportive services, physical environment, training, workforce development, engagement and involvement, processing, monitoring, quality assurance and evaluation, cross-sector collaboration, governance, leadership, and planning. And so there's, if you go to the next slide, I'll show you just an example of the organizational assessment. So this is domain number 1, where we have a description of the domain, and then you can see the various indicators. And the indicators are specific to policies that the organization has or practices that the organizations carry out. And then, of course, they had to use a 4-point Likert scale in evaluating themselves against those various indicators. So hard copies were submitted to the AIDS Institute for analysis, and each organization received their own data report, and aggregate data was shared via a coaching webinar. And what we found is that a lot of the organizations felt like they were doing the work, but they may not have had policies that really stated what their practice was. And so we're just sort of combing through all of that information at this point. Next slide. So the next piece is patient satisfaction, right? So we need to figure out like how satisfied are the patients currently with the services that are being provided to people who use drugs. And then again, like I said, we will assess this after the year-long participation in the year-long initiative. So patient satisfaction is used to obtain a better understanding of the patient's experience and to develop methods to improve on the patient experience based on their feedback and responses. So this was a totally anonymous survey. And I should say that the staff assessments were also anonymous as well. So we asked each of the organizations to pull a random sample of patients who were identified with an ICD-10 code as having a substance use diagnosis. Organizations were able to offer incentives as an option, although the AIDS Institute did not provide funding for those incentives. And we asked each organization to complete 30 patient satisfaction surveys. And so this was a bit of a challenge for the organizations. And so what we heard, again, sort of feedback that we're getting on the patient satisfaction surveys is that it was difficult within the time frame that we had set forth to capture as many surveys as needed among people with that specific diagnosis. Or individuals may have had an appointment during the time period we wanted them to complete the patient satisfaction tools, but then they missed that appointment. So we need to learn from our experience with the patient satisfaction survey as we move forward. Next slide, please. So this is, again, just a sample screenshot of some of the questions on the patient satisfaction tool. So I feel comfortable telling the staff and my providers at the clinic about my drug use. And so we had them answer a question like that. I was upset at how long I had to wait for my appointment. So some of these questions are probably questions that are used all the time to sort of assess patient satisfaction. Next slide. So the last part of this initiative are monthly coaching webinars. And so these are monthly webinars using WebEx. The webinars are not only open to the 2 individuals participating, 2 of the champions for the organization, but they're open to all staff within the participating organization. Each webinar focuses on one of the domains in the organizational assessment. And so it's very specific and focused on what that domain is all about. We've identified faculty. Most of them are derived from the advisory group. And so the faculty have to put together their presentation. They have to come up with some discussion questions. We like to say they have to come up with some homework, which are more learning activities. So for example, they may share an article that's relevant to the particular domain. And therefore they may have some discussion about that article during the webinar. So the coaching webinars have been really interesting, as we now have held about 4 or 5 of those webinars, and the webinars go through September. Next slide, please. And so as I mentioned in the beginning, this is a learning collaborative. And so one of the things that we wanted to be able to do is to utilize a learning collaborative website. And so as you know, SharePoint is an example of a learning collaborative website. There's other examples of those websites as well. SharePoint has some limitations. And so we chose to use Glass Cubes. There's a discussion board where you can post questions, you can share information, you can sign and task management. There's a calendar where we post the webinars and any other activities that may be coming up. We share a number of resources. We have set up folders for the coaching webinars where we have the presentations, where we have the homework materials. I have to say, there has not been a lot of back and forth sort of collaborative discussions on this website. Again, you know, hindsight is 20/20. I think we went in with the best intentions. But again, a lot of these folks who are participating are clinicians, and so therefore they may not have time to really engage in some discussion. So we've been really trying to come up with other ways to engage, such as using chat functions during the webinars or polls during the webinars to really get feedback from folks We're also encouraging, now that they've done their organizational assessment and we know who might have some best practices, we're encouraging those individuals to talk about those best practices on the coaching webinars. And we're also encouraging those organizations that have best practice policies to also share those with organizations who may be in need of some improvement. So the last slide, please, is really listing all of the folks that were involved in this. And this was really truly a collaboration across the AIDS Institute and across all of the key stakeholders. And so on the left-hand side, we have mostly our AIDS Institute folks here. Emma Roberts, some of you may know from the Harm Reduction Coalition. She was also an advisor to us on an internal work group. So we meet internally, the AIDS Institute staff and Emma Roberts, we meet internally monthly to talk about how things are going and to plan ahead. And on the right-hand side is the list of our advisory panel members who, again, advised us on every step of the way with this particular initiative. And I really, this is really, I really wanted to take some time to acknowledge them, because it really has been a lot of work and a true collaboration. So the last slide, if you don't mind, is showing is my contact information. As I said, you know, this is sort of like a pilot for us, and we're learning as we go. We have some lessons learned already about where we might need to change some things up. The organizational assessment tool, just need to give a shout out to Norelle Ellenden and Lila Hunt. They were really the pioneers with this organizational assessment tool in developing the indicators, also fleshing out some of the language around the domains as well. So we hope that that's going to be a really useful tool, not only for us here in New York, but for those out there in other states looking to do this work. So thank you. And I will take a couple of questions, but I do have to jump off rather quickly.
Great, Colleen, thank you so much. I found one quick question from Bernie about the assessment tool being on the Likert scale. 4 is a neutral option, correct?
Let me just pull that up again. It's been a bit since we worked on the assessment tool. You know, I have to actually look into that in terms of whether or not 4 was a neutral response. I can certainly get back with that information. But I just want to look at some of the original documents with that.
Great, thanks, Colleen. And I had a quick question, and I guess I was just curious. You know, this is such a cool project, and I really appreciate you sharing it. It's like very impressive work. Is there hope to extend this outside of the Learning Collaborative once your time frame is up? Like, is there a hope for future rollout with a bigger group of providers?
Yeah, absolutely. I mean, that's the whole intention. I mean, we can't stop with just this 11 participating organizations. There's so much work that needs to be done. And yes, I mean, we would really like to be able to run this as frequently as possible. And you know, we've talked about that. You know, it would be great if we could get additional funding. You know, our trauma-informed care initiative that is similar to this is actually University of Buffalo is the contracted organization that actually runs that particular initiative. You know, full disclosure, it takes a lot of work. This has been, you know, a lot of work on all of our parts to keep this going. So, so we need to make some tweaks. We know we need to make some tweaks, but absolutely, we really want to package this up and do this again. And like I said, be able to share this with other states and organizations that are interested in doing this work.
Great. Thank you so much, Colleen. It's, like I said, a really impressive project, and I'm excited to, you know, follow it as we move along. I do know that you have to jump off, so any questions that are directed at you or towards this project or about this project at the end, I'll make sure to get to you and connect to answers and information with people. So thank you again.
Thank you. Thanks again, everybody. Take care.
Cool.
Bye-bye.
Wow. Okay, great. So now we're going to move on to some old, you know, colleagues of mine out in Colorado. So this, we're going to hear from both Lisa Rayville, the Executive Director of the Harm Reduction Action Center based in Denver, Colorado, and Matt Slavey, who's on the board and part of Liseo Images. And they are going to present some of their community-based anti-stigma work that they've been doing over the past many years. So I don't know who wants to start from y'all out there. but
I'll start.
Great.
It's me, Lisa. Well, thank you. We really appreciate this opportunity. Thanks so much for having us today. I didn't do much with this, and so I'll give most of the time to Matt, but I just kind of wanted to talk about, the community-based organization that's a direct service provider. A lot of times we don't have the luxury or the opportunity to be able to do media campaigns or work closely with folks that, really understand our issue and communication. So this really started with us about 8 years ago. Matt came to us through a colleague in the community, wanting to learn more about what we do and something that would help us push forward in the community to reduce stigma. And it started with photography, which you'll see today, and then he did another campaign with videos with drug users, and then the third tier has been most recently, and he's done some cartoons, not only for our Harm Reduction 101, which is a really fun way for folks to learn about that, but also with supervised injection facilities too. Today, I think we're going to specifically focus on the photography campaign. And what was really nice for us, and there was some concern from me in the beginning, is, a lot of times, not the journalists, and a lot of times when journalists come in, there's problems of being exploitative or things like that. And so we were really concerned, and I was extremely skeptical, which you'll see in my third slide there, about working with him, but I'm just feeling really good about kind of where we're at and where we're trying to go. We have used the photography for not only inside the space, but outside of the space as well, and using it for booths in the community, on social media, to start conversations and to be able to really talk about those that we've lost, and how we're fighting like hell for those still living. And then we were able to get them up in the Capitol, so we're perfectly placed right across the street from the Colorado State Capitol, right where we should be. So we were able to get the photography campaign in there for about 3 weeks, if I remember correctly, and it was right at the start of when everyone would go through, I think it was around Overdose Awareness Day in August, and right at the start of where the tours would be as well. So we really wanted to make sure that this campaign kind of got out there. And I think you'll see on the second slide, if you want to go to that one, just kind of, this is Matt, who will speak on his own here shortly, just kind of talking about why he thinks it's really important that the media pay attention to what we're doing and to do it with love and care. And when we initially started the photography campaign, we've only had syringe exchange and naloxone access in Colorado since 2012. And so, we're only 6 years in with that, and so we're definitely behind New Mexico. But we were really trying, as soon as we got syringe exchange, we knew we needed access to naloxone, and which is where the photography campaign was kind of born. If you want to go to the next slide. And then I was skeptical. I'm very clear about that. Partnering with a photojournalist, because that can be very problematic, not only currently, but especially 8 years ago. But if you want to go on to the next slide, and I'll have Matt, who is still a current board member. He was not when we first discovered him, but he is now, and if he can go ahead and take it away.
Sure. So my name is Matt Slaby. I'm from an organization called Luceo. We do strategic media for advocacy-based organizations. So you think about what that means. That's creative and production and strategy for organizations that work on harm reduction and public health, immigration. We've been doing a lot of work at the intersection of criminal justice and mass incarceration lately, and topics of this bent. So as an organization, we began as a group of journalists and media professionals, and lawyers. I'm the intersection of a journalist and a lawyer. I don't know whether in the current climate that makes me a person or fake news, but this is where we're at. So I'll get into speaking about the photographs that are going to present to you in just a moment. But there's a couple of things that I wanted to explain first off. So coming to this issue, and I don't know who's listening or who's connected right now and how they think about this stuff, but coming to this issue, I came relatively naive. So my background, long before all this stuff, I worked for an ambulance company. I worked for Columbine Ambulance in Littleton, Colorado for 6 years. And it's a high volume ambulance system. We did about 17,000 calls for 3 ambulances per year. So on a 24-hour shift, fairly busy and fairly involved in terms of coming in contact with the subjects of this particular issue. I came to this topic years after leaving that job, still skeptical about what good harm reduction could do. And one of the things that I really appreciate about working in journalism is it makes you shut off your judgment long enough to listen to what people are saying. And I'm thankful for that, because what's happened over the last several years is I've gone from being somebody that was interested in harm reduction, casually interested in understanding how it worked and how it connected to these bigger stories in the United States, to somebody that's a committed advocate for harm reduction. So that puts me down the road, that puts me on the board of the Harm Reduction Action Center, and that ties me to a lot of other organizations, some of whom may be listening on the phone right now. Because it's personal, and because it's something that's really changed me, let me back up. There's something that I want to explain. There's one thing about journalism that's always troubled me. And when I would go and work on stories and present those stories to magazines and they would go to the public, one thing really, really bothered me. And that was that in cases where there's a clear solution, where something is obvious and we can make progress on it, is the story enough? And the answer specifically to the opioid crisis and to harm reduction is the story is not enough. We have to be asking for something as we're doing that. We have to be advocating for something as we're doing that. My thesis more or less on how media functions, whether it's photography, whether it's text, whether it's video, is that these are opportunities to reframe it. It stops people's brains, and it's an opportunity to reframe the issue long enough to let people make some progress on how they think about some things. So getting into the stuff that we're going to show today. Early on when we were talking, the one thing that we really identified as a significant barrier for the general public, for people that were not familiar with how harm reduction functions and why it works, was just connecting the dots between the people that it serves and the people that are involved with harm reduction and everybody in real life walking around out there. So we developed this very simple concept early on, which is how do you connect that? How do you humanize an issue without over dramatizing it or without showing details that further stigmatize the issue? And so what we did with this first photo project was we simply showed people that you know and places that you go. So in this series of photos, and we can run through it relatively quick, on the left side is a portrait of a person who uses drugs. All of the folks I think in this series are either somebody that uses drugs or somebody that's connected to somebody that uses or has used in the past. So on the left side is that picture, and what we did is we tried to take an aesthetic that was human and gentle, and leave the syringes and everything out of the image. And pair it up with a place that was significant to their story, particularly their healthcare story. So where did they overdose? Where did they contract hepatitis C or HIV? Or in at least one of the photographs that's in the series, where did somebody that they know die? And in doing that, we're asking the viewer to look at this through a different lens, to connect with these folks, the folks that are in the images as people, and to recognize that the places that these folks have these very significant points in their story arc, to recognize that those are places that we're all familiar with in Denver, or that is at least universally familiar to folks. So if you wouldn't mind, Alyssa, just clicking through a few of these. So actually, we'll click faster through the next few, but this is this image right here is Helen. And so just by way of making an example of how this works. I'm sorry, did somebody say something? Awesome.
No, you're good. Thanks.
So the woman on the left, her name is Helen. She's also on the board of the Harm Reduction Action Center. Her son is on the pin. She lost her son to an overdose several years ago. Her son was in the house that he overdosed was a house where several of my own personal friends lived. We were always two ships passing in the night. But once I met her and started to make that connection, this really did come full circle for me and become something that was deeply personal. So next slide. So I'll just give the brief captions for this. This is Lynn, and where Lynn was living and where she experienced an overdose. Next slide. This is Nick, and also where Nick was living and experienced an overdose. Next slide. Alan, the place where his camper was parked where he experienced an overdose. Next slide. Fowler, same story. Next slide. Zach, and same story. Next slide. Great. So that body of work was early introduction to harm reduction for me. It appeared in Mother Jones several years ago, and I think it still exists on their website right now. What that did for me and my organization is it opened up a place where we really felt that we could put down roots and continue to work for positive change. So we created a number of tools for several different organizations, but particularly for the Harm Reduction Action Center that address stigma as the fundamental barrier to why we, or at least the fundamental barrier to the changes that we hope to see. So I don't think we have videos embedded in this stuff, but
We actually.
We do.
Well, we have links.
Great. So if you go, I mean, if anybody is, so why don't we play the other video, the cartoon?
Okay.
And just in the interest of time, I'll leave it at this one. This is a body of work that we've been doing with the Harm Reduction Action Center most recently. So we've developed a series of simple explainer videos. For everybody on the line, you can see this is about 2 minutes and 34 seconds of your time. But this is 2 minutes and 34 seconds that explains harm reduction in plain language in a way that keeps people engaged for the duration. We have other videos that are complementary to this that explain overdose and that also explain supervised use, supervised consumption. All three of those videos can be found on one of the web tools that we've developed, which is at stoptheclockcolorado.org. Stoptheclockcolorado.org shows where you can find naloxone. It geolocates you and shows where you can find naloxone anywhere in the state of Colorado that has it over the counter. But if you wouldn't mind, if you'd play Harm Reduction 101, and I will await any questions at the end of this if there are any.
Great. And so I'm going to try to play it, but I want to, if you don't hear the sound right away, we might try something different because we might have to change something on the back end. So I'm going to give this a go and let's see what happens. And if this doesn't work, we'll switch the way we play this. You don't hear sound, right? Okay.
No sound.
Okay. So we're going to do a quick switcheroo, which might take a second. So I don't know if there's anything else you want to share while on the back end we try to figure out the best way to play this.
Yeah, sure.
Thanks.
The only other thing that I would share is that being involved with harm reduction has been an incredible gift to me over the last several years. It's right now has taken me to Portugal, where we've spent the last week looking at decriminalization and drugs out here, and it's really brought home something that I find really compelling, which is I'm talking to you all sitting in a car, just a little bit south of Lisbon right now, a computer. Yesterday, we interviewed folks at one of the harm reduction organizations inside of Portugal. And, they said something that really struck me. They said, first, the issue is really complicated, but don't overcomplicate this issue. And to understand what that means, there's been 40 overdoses. The most recent data set for this country shows 40 overdoses in an entire year. And to contextualize that, that's about 4 hours and some change in the United States. Now, population and use and supply all complicate this issue a little bit. But for us, that's a story of hope, because if we don't go too far with it, there are models that are getting ahead of this, and that's encouraging. Any luck on your end?
Yep, we're really almost right there. I think that we're trying to share my screen instead, because technology is our friend, and we're hopeful that it will play.
I think we've figured this out. So let's try this now.
Can you all hear it?
Nothing.
Okay, hold on one sec. Technical difficulty. We'll try again.
And if playing it is too difficult, for folks that are listening, the easiest way to find this is the first video up on stoptheclockcolorado.org. There's 24 hours in the day, and this will take 2 minutes of your time.
Sorry about that. It was a little more complicated than we realized, but we can share the link to these in the chat box to make sure that it's easy to access and people can watch it on their computer.
Oh, please do. We appreciate it. Anyway, I'll cede the rest of my time to Lisa. I don't know if you have anything else that you'd like to share. Otherwise, questions if there are any.
Yeah, great. Thank you so much, Matt. Sorry about the technical difficulties there. It's really, those are such cool videos, both about supervised use centers or sites and harm reduction 101. So I really appreciate you also sharing your personal story about learning about harm reduction and how it's really shaped your response and your work right now. So thank you. Lisa, did you have anything else to add on in there?
Go ahead. Click to the slides. Okay, I think that might be it. Okay, so this is us. If you have any questions, issues, concerns, this has really been Matt's brainchild and baby. And like I said, I was initially skeptical, and now I love it. And I use these videos and presentations and really talk about where we're at and, like I said, where we're trying to go. So please feel free to reach out. StopTheClockColorado.org is a really great website to be able to get those videos. HarmReductionActionCenter.org, we also have videos on there as well. If you go to our website and then hit the YouTube link, we have a whole bunch of those anti-stigma Stigma Kills videos on there as well, which run about 15 seconds to 30 seconds. Folks are more than welcome to push them out on their social media to start conversations. We have the pictures on the photographs on the website as well that folks can download and push those out too. So feel free to use any of that and talk about your own harm reduction efforts in your own community. Thank you for having us today.
Yeah, again, thank you so much, Lisa. That's really super helpful. I've always really admired this campaign and all the, media that you all put out and create to really make harm reduction feel more accessible and more human. And it feels like, throughout this conversation that, making people who use drugs, actually be treated as though they're humans, which is they are. So that, feels like an obvious lead in. It's really, it's really the key. And yeah, I just appreciate you all sharing because you do such a great job of that.
Thank you.
I know, it's just so good. So I guess, one last thing I want to mention about the Harm Reduction Action Center materials is that this is an opportunity, and it has been used sort of throughout Colorado. As far as on overdose prevention days, there's health departments at Boulder, I think, and some others that I've heard of that sort of, use these materials and partner with the Harm Reduction Action Center to create awareness around overdose in particular, and then also just breaking down stigma within our communities. And I guess I was curious if any of the panelists who are still with us would talk about sort of building those bridges with both different departments, of health and human services or injury prevention, or with community groups, or for Matt and Lisa, kind of the other way around, kind of advice you'd have about sort of building those partnerships with different community stakeholders.
This is Bernie. I have a thought on that real quick, if that's okay.
Please.
I was in Wyoming last week doing some work with SAMHSA and small communities up there. And one of the things I think is really important for people to remember, even if you've been doing this for a long time, to remember that this is a marathon and not a sprint, and relationship building is really, as trite as that may sound, is really super important. And that I have found that if you come to whatever organization you're engaging with, who may be resistant or who may have issues associated with stigma and discrimination, to do your best from the harm reduction perspective to be with them where they are and to listen to their issues and concerns, and that over time those relationships, having been built sometimes over the course of a couple of years, shifts do seem to start to happen, and people start to hear what you're saying in a new, different way, and change their perspectives on this. I'll give you just a real quick example of a Santa Fe City police officer who has had a couple of reversals in the city of Santa Fe, and who conveyed to me how neat it was for him to be able to save somebody's life, and how that had changed his perspective on people who are using heroin in Santa Fe. And there's nothing that I maybe could have done in the short term to work with him to have his perspective shifted, but it was one of his captains that mandated that he be trained to carry naloxone and respond to the community. And that relationship that I had with that captain helped to, and that captain with that officer, and him responding to a couple of overdoses and saving people's lives, humanized it for him in a way that I don't think anything else could have done.
That's great. Thanks so much, Bernie. Any other thoughts about, advice to give to folks on the call about how to build those relationships? Particularly any advice about building those relationships? You brought up law enforcement, but building those relationships with sort of historical people who, aren't historical partners to health departments or social services. Any other thoughts? Okay, hearing none, which is just fine. I'm okay with that. So we did hear from New York State about gathering information on patient satisfaction. If patients are feeling stigmatized, like their services are appropriate or suitable or welcoming, non-judgmental. I guess since a lot of you work in community and also, you know, run programs that focus on people who are working with community, if you can talk a little bit about how you all gather, you know, information on, you know, either patient satisfaction or participant satisfaction, really just trying to put the interests and aims of the drug user, the person who's using drugs first. All right, so hearing none, I just want to throw out for one more minute that any other questions that participants have about, you know, that could be directed to the panel in general or to NASDAQ or anyone in particular on the panel, you can feel free to forward to me at, you see my email there, lpegram@nasdaq.org, and we can hook you up with the right information and the right folks. Just lastly, is there any final comments or responses from our panelists? All right. Well, I think that you guys are going to get 15 minutes back from our pretty expansive block of time that we put out there. I just want to thank everyone for presenting their work and their efforts on this. It really feels like a universal challenge, and that, you know, is so different from place to place. It's just so good to hear such a range of approaches and a range of different programs, all trying to work on the same essential issues. So again, I appreciate your work. I appreciate everyone who's on the call, and hopefully got something out of today. And thank you again. I hope that everyone has a great afternoon. Great. Thank you so much.